Dr. Asha, you can start.
Hello, everyone. This is Dr. Asha Jain, President, Raipur Obstetric Gynec Society, and I welcome the Society of Fetal Medicine, Dr. Ashok Khurana sir, Dr. Chinmayra, Dr. Aparna Sharma, for coming on to this program. And today they'll be talking to us about preeclampsia. Preeclampsia is every gynecologist's nightmare, and 3 women out of every 100 who deliver suffer from it. So the incidence is really very high. And you know, when a woman comes to you at 28 weeks, Namaskar, Dr. Praveen, 28 weeks, 30 weeks, and suddenly you see that her BP is, means I recently went through that I had a patient who came at 28 weeks with first time blood pressure of 190 by 140. And there, before that, nothing ever. Now, if as gynecologists, we are able to predict that this woman is going to go in for PIH and prepare accordingly. And it's such a simple treatment. Only thing is that patient came to me in the 6th month. She didn't come in the first trimester. And at the end of 6 months, she went into such severe PIH. So we need to learn how to predict preeclampsia so that prematurity can be prevented. We can get better babies, and you know, the gynecologist will also age less, because having every 3% women going into the severe PIH and you know, worrying about the mother and the child, and today about the fallout with the relatives, takes away quite a few years from every gynecologist's life. So let us learn today how we are going to prevent PIH and make our lives easier and the lives of mothers and children better. Welcome, sir.
Thank you. Thank you very much. It is indeed a privilege to be back for episode 3 of the Essentials of Clinical Fetal Medicine, which, as you know, we do, Society of Fetal Medicine does with the Raipur Obs and Gynae Society. It's an idea that we came up with a long while ago. It's taken great shape now, and it's one of our most well-attended meetings. Yes, I know we've suddenly got back out of COVID mood and into heavy work mode. So we might need to change the timings by about 15 minutes. We'll try and consider that. We receive that as a request. We'll consider that. But let me start on time today without any further delay. And I will try my screen share and make sure it's being shared. Is everybody now able to see my screen share as yet, or do you see a completely black screen?
No, it's seen.
Marvelous. And you see my arrow pointing nicely, and my video, of course, is
yes.
Wonderful. So what I'm going to take you through is preeclampsia prediction and ultrasound surveillance. We've talked a lot about preeclampsia prediction, which is a first trimester test essentially, but what we haven't spoken about too much is the ultrasound surveillance later in pregnancy. We've had a few webinars on it, but there is so much that has happened in the last 18 months, and every month there is something new added on, that I figured we needed an update. So I have first a formal presentation, which will take us through about 45 minutes or so. And then we've modified our panel discussion today. And I know that everybody will be happy to know that although we have one formal question at the beginning of the panel, we actually have a complete open session of 30 to 40 minutes for our attendees to ask any questions that they wish, and we will answer each one of them, because irrespective of the number of questions and irrespective of the time we allot, we never seem to have enough time for the questions on preeclampsia. And yet it's so important, and we desperately need to do something about it, because like you heard, there's 10 million women around the world that develop preeclampsia every year, that 76,000 pregnant women die each year from preeclampsia and other hypertensive disorders. And when you translate that into actual figures, it basically means that by the time we're through with tonight's program, we're going to have a large number of women dying of this disease, and we need to do something about it. The same thing applies to babies. 2.5 million preterm births are caused by preeclampsia each year, because we need to deliver them preterm iatrogenically, and it contributes to so much mortality and morbidity. We really have to do something and try and prevent this condition. And the good news is that yes, something is available. And that's what we're going to discuss. We do understand that hypertensive disorder is about 18% of the direct causes of maternal mortality, and that preeclampsia is far more common than Down syndrome, for which we make so much noise about. And the other thing is that it contributes a large amount to fetal growth restriction. And therefore, we're really looking at a disease prevalence of about the 3% the doctor was referring to, although we have pockets in India that have a published equivalent of 27% in some pockets in the country, particularly places where there are poorly developed health services. Also, we know that the only real treatment in this situation is to deliver, that means to stop the pregnancy, to terminate the pregnancy, to prevent maternal morbidity and mortality, and to prevent fetal death, as well as prevent fetal damage. So what do? Well, good news, a personalized risk estimate, and I repeat, a personalized risk estimate, which is an estimate for each woman, not the whole population, is available for the entire obstetric population, not just the ones at high risk or the ones who've had trouble before. Therefore, this includes nullipera, and this is all available in the first trimester. If we have women who are screen negative from this process, you have almost like a 99% plus chance that preeclampsia will not occur. We know that you can then start low-dose aspirin at the right time, and that this will improve perinatal outcomes, and we will discuss those. And also that surveillance and testing in later pregnancy facilitates prediction of preeclampsia. And this is extremely important, and I'll discuss it with the help of a slide as we go along. With all this data floating around, we will therefore need to understand this problem a whole lot better. So I'll take you through some minimal basic sciences application, the screening method, the method of prevention, which we will also discuss in the panel, the surveillance for pregnancies, which are singleton pregnancies, screening in twin pregnancies, some newer approaches, and of course, screening in resource-restricted populations, which we will continue to have to cater to. After all, a lot of our population comes under that category. We'll also give true important emphasis to the low-dose aspirin and make sure what this 81 milligrams mean and what we can do about it. So starting right at the beginning, we know that we've expanded the first trimester screening a long time ago to go beyond screening for aneuploidies. We were screening for fetal number. We wanted to make sure fetuses were alive, and then we were dating the pregnancy. And then we would go ahead and do either a nuchal translucency or go on to then assess the nasal bone and additional parameters. And then we realized that yes, in this same situation, we can expand our palette and include screening for preeclampsia, which is the big killer, as you saw on that list. You can, of course, do all the other things in the first trimester as well, and I won't repeat those. But the other piece of good news is that this makes complete economic sense. When we screen for breast cancer, we need to screen 377 women to find one breast cancer. When we screen for cervical cancer with either HPV testing or a pap smear, you need from 1 to 2,000 women to identify one woman at risk. And for male cancers, 1 in 1,400 for prostate cancers, and for all cancers of the colon, 1 in 871. But look how efficient preeclampsia screening is. In preeclampsia screening, to detect all the preeclampsias, you have to screen only 143 women. And to detect the serious preeclampsia, which is before 34 weeks, you only have to screen 400 women to find a woman who will benefit, who would have truly benefited from that screening and would have benefited from the institutional low-dose aspirin. So this makes complete economic sense, even in low source economies. And this is why I wanted to bring up this whole topic, because we have realized last year that screening for preeclampsia also gives you a very good idea of the other great obstetric syndromes, and we can develop a risk for a lot of other women as well. For instance, every woman has a personal risk, which we will just show you how to calculate. You start treatment then before 16 weeks with low-dose aspirin. You calculate a placental risk based on uterine artery measurements, based on her clinical features and based on biomarkers, and you say, okay, low-dose aspirin. If she has pre-existing hypertension or she has had some evidence of heart disease, hyperlipidemia, etc., Again, early blood pressure management and low-dose aspirin. If she has a metabolic risk, such as polycystic ovaries or diabetes or prediabetes or insulin resistance, again, you can not only have low-dose aspirin, but also add on a safe statin, which is pravastatin, and perhaps metformin as well, depending on what the background is. And if she has a thrombotic risk from either a specific immune syndrome or a previous history, again, low-dose aspirin and D-specific anticoagulation, and of course, folate for those which have a high homocysteine. So that is actually a panoramic view of what you can actually achieve. And I will show you why, because of this situation, we also have to go a little further, and that is to add on risk factors as the pregnancy goes along. Because when we start the pregnancy, we know that most cases when we screen are likely to be identified, and that is called the detection rate, and we have very good detection rates for preeclampsia. Some will be missed, and we call those false negatives, and that is very small with preeclampsia. And some cases may never develop the disease, which means it was a false positive screen, and we don't worry because that again is very low with preeclampsia. But the main information we're looking for is that there may be trouble ahead, and then what do we add on to specify the trouble? What do we add on to improve our healthcare services, and how can we contribute to all this working out correct? Let's see how we've been working so far. We've got two models, and perhaps three. There's one from Canada as well. And if we go by the American guidelines, they call high risk factors as previous preeclampsia, chronic renal disease, chronic hypertension, diabetes mellitus, and either systemic lupus or antiphospholipid antibody syndrome. And in the NHS or the NICE guidelines, you have previous preeclampsia, chronic renal disease, the same, and the same. The NHS also adds on moderate risk factors, which is first pregnancy, age greater than 40 years. And they don't like to think that anybody more than 35 years may be worth screening, which is tragic because a lot of women between 35 and 40 are more prone to preeclampsia. They use a body index of much larger women compared to the Americans. So they're not at all liberal in wanting to do anything for these women. And an interpregnancy interval of 10 years, which we know is there, and a family history. What the Americans have very kindly added on is that if you are Black or you're poor, which means they do respect Black, which is good, then they will look after you a little better and maybe care for you a little more and give you the right thing. This is very nice, but look at the detection rates. If we were to look at the Acog guidelines, the detection rate is about 5% with a false positive rate of 0.2%. We have the NICE guidelines, which are a little better, 39%, false positive rate 10%. But look what happens when you work with this, which is the Fetal Medicine Foundation parameters, maternal characteristics combined with uterine artery Doppler, mean arterial pressure, biochemistry, which includes PAPE and Plgf. We have a detection rate of 75% for all in the original studies. But then we had a meta-analysis that came along in 2017, which said that for the serious preeclampsias, if you went the whole hog, you would identify 100% of women who would develop preeclampsia before 32 weeks. That is the aim today, that we need to identify these women and do something for them because it's possible. The Canadians also have that row of things. And then, of course, they develop the indications for aspirin that in the NICE guidelines, if you have one high or more than one moderate, you're entitled to aspirin. Acog, if you have one high and they forget about the moderate, they don't mention that. The Canadians say any of the above and they're willing to do something for you. The aspirin dose in the Canadians is unclear. America likes to offer only 81 milligrams before 16 weeks. That's their manufacturers. They've influenced them. They don't want to use their brains, and that is tragic. The NICE guidelines are becoming partially intelligent and accepting that, yes, there might be aspirin resistance, so they might raise to 150. The fact remains that aspirin resistance is more than 33% in pregnancies, and therefore it's wise using 150 milligrams from the beginning. We've learned that from heart disease in adults. 30 years ago, we refused to accept that, which is tragic because the manufacturers say 75 or 80, simply because that seems to be safer for the gut, but it's just no good for looking after preeclampsia. We must stick to 150 milligrams, and we will emphasize this again. Aspirin duration is until delivery for most, and now we believe that aspirin, according to the FMF calendar, needs to be given up to 36 weeks. And that is the way to go about it. The important thing to remember is that this is all published stuff. This is not imagination, and we have every reason to follow it. We do understand this whole process starts very early in pregnancy, soon after adherence, where once the embryo burrows in, you actually have this in situ trophoblast, which eats into the blood vessels and replaces the endothelium with trophoblastic tissue. And as a consequence of this, the entire endothelium gets replaced with trophoblast, and blood vessels become less tortuous, much wider, and can convey as much blood as the pregnancy wants. Whether this happens as a consequence of maternal hemodynamics or it is a local trophoblast factor remains a matter of controversy, but the fact is this happens. Importantly, this happens in 2 waves. The first wave at 8 to 10 weeks, and the second wave starting at 16 weeks and going on to 24. What does this mean? This means that if we find something wrong in that patient and we're able to start before 16 weeks, we overcome a bad second wave and we overcome the effect of defective trophoblastic invasion of the spiral arterioles. And that is what we're truly aiming for. Now, when we look at abnormal presentation, we realize that there is a cascade. There's abnormal trophoblastic invasion, placental ischemia as a consequence. This activates the endothelium, which results in vasoconstriction and microthrombosis, 2 things that lead to less blood flow through the placenta. Diffuse narrowing of vessels, which is not a disease caused by the atherosclerosis, but just vasospasm. And therefore, outcomes can be improved by reducing vasoconstriction and by offsetting microthrombosis. And that this forms a basis for growth restriction, abruption, preeclampsia, HELLP syndrome, and stillbirth. Therefore, we are able to handle all of this when we use this formula. And again, there's proof of this last year in a very well-written paper. What I wanted to point out here was that this is a cascade. And therefore, what you see in the beginning of pregnancy when you identify placental ischemia might not be as dramatic as what we see once activation happens and you get vasoconstriction, microthrombosis. And therefore, when we use the kind of model that we were referring to, those are known as logistic regression models, where you look at risk factors and a few others. They're not as efficient as when we call a model a competing risks model, where we add on factors as the pregnancy advances and then predict more accurately as pregnancy advances, so that then you can actually have a very efficient system in place that gives more attention to those pregnancies that need more attention. And we will discuss this competing risks model. And the aim, of course, is to get the presentation correct. What are the biomarkers we have and what happens here? In the first trimester, decreased uterine artery flow, low PAPE, low PLGF. When endothelial activation takes place, you have low PLGF and a raised SFLT, which is a biomarker, maternal blood, and then, of course, the frank clinical picture, which is the definition of preeclampsia. So essentially then, what we're looking at is something where we use a basic model and we add on to that as we go along. So what we were referring to originally, maternal factors plus biomarkers and the FMF model for the first trimester, is a logistic regression model. It cannot be easily expanded to include additional biomarkers as the pregnancy advances. It does not take into account the increasing effect of biomarkers with the severity of PE, and therefore it's a static model for the first trimester. It's a very well-researched model. You can see that from 2007 onwards, all the way up to 2014, there was a lot of research done, excellent seminal papers. All of these have been revised between 2017 and 2021. And therefore we realized that, yes, this is the way that we need to go. And this is good research. When we look at the other model, which is the competing risk approach model, it starts off with a personalized risk, but it gives you risk of preeclampsia at any desired gestation because you add biomarkers. It can be easily expanded to include these additional biomarkers measured at any gestational age. It takes into account the increasing effect of biomarkers with the severity of preeclampsia. After what is preeclampsia? We know that every woman, even if she's low risk, will get preeclampsia if pregnancy goes on indefinitely, and thank God pregnancy doesn't go on for more than 41 weeks. What these biomarkers do is to shift the peak, which would happen. That means at 56 weeks of pregnancy, every woman would have preeclampsia. This horrible peak shifts to closer and closer to early pregnancy as these biomarkers increase. And that is what is called the effect of newer markers. And that's why we need a competing risk approach and not a logistic regression model. And the best model we have so far is this, and this has been expanded recently. We use maternal characteristics, uterine artery Doppler, mean arterial pressure, and PAPE and PLGF, put them into software, and you get an answer. Let's see each one of these. And we start here with a mid-sagittal section of the uterus and cervix. And the transducer is gently tilted sideways so that the uterine arteries are identified. You see them right here. And high velocity blood flow along the side is seen. The pulse wave gate is then placed so that it includes the whole vessel. And this is usually about 2 millimeters in size. It's positioned on the ascending branch of the uterine artery after it's given off the descending cervical branch. The inclination angle should never exceed 30 degrees. And in order to verify that the uterine artery is being examined, just make sure that the peak systolic velocity should be greater than 60 centimeters per second. Otherwise, you may be sampling the wrong vessel. Then when you get 3 good waveforms, you go ahead and measure the PI and use that in your calculation. Do remember that on transvaginal scans, uterine artery resistance is higher, and therefore you have to use a different chart. The 95th centile is used for the mean uterine artery PI, and that is the cutoff used. We don't use any other parameter. The 95th centile using a transvaginal approach is relatively different. And if you want a single cutoff, well, at a CRL of 65 millimeters, it's about 3.1. But I really suggest that we should use charts that give us a true cutoff. Remember also that the vast majority of this work can be done by visualizing the uterine arteries by a transabdominal scan. So unless there is any other indication for a transvaginal scan, such as the need for greater detail of fetal anatomy, you don't really need to do a transvaginal scan. Remember that it can be altered, the uterine artery PI can be altered by BMI and by previous preeclampsia and ethnic origin, but we sort of realize that this is all included in the final formula calculation. We always use a chart of the uterine artery PI that we feel comfortable with. I use this expanded chart from 1991 that came out in Fetal Diagnosis and Therapy. We see the left side, we see the right side, and we take a mean of the two. We also realize that this kind of a low flow velocity, low impedance flow velocity waveform is something that is rarely seen or not so commonly seen at 12 weeks. What we normally see is a high impedance with a notch, and we used to make so much noise about that notch, we realized that notch has no value. Most of these notches will be there, but that value gets taken care of when you calculate the PI, and therefore that's the way to absolutely use this, and that's the way to go about it. The next thing we realize is that we do not use the ST ratio, we do not use the resistive index, we use only the pulsatility index, simply because it's more stable and it does not approach infinity when there are absent or reversed diastolic values. So therefore, we use the PI. Its advantage over RI is also that it includes the average velocity of all maximum velocities during the cardiac cycle, rather than just the 2 points in the cardiac cycle as we use for an RI. So we use a mean PI, right uterine artery PI, left uterine artery PI divided by 2 irrespective, and we use it throughout pregnancy. And the notch, we throw it out of the window. There's a lot of research, and you can see it all cited over here all the way up to 2018, because people refuse to unlearn and learn again. But the important thing is that yes, we ignore the notch. The notch has no value today. Notch plus PI, no value. PI, PI, and PI value. So we must then throw the notch out of the window. Mean arterial pressure. Not so easy to take, but possible. The patient should be relaxed. Not too much of interference. In the West, they suggest keeping your mouth shut. If you keep your mouth shut, your patient is going to get terrified in the Indian context. It's nice to talk about other things, the weather, that everything is well at home, that COVID is going away, and so on. The cuff size should be selected carefully. It depends on the mid-arm circumference. And you have to be very careful because cuff sizes come in S, M, and L, which is small, medium, and large. Small is for the pediatric age group. Adult women need to use medium or large. We also have a different size in the north. It's called the P size. P stands for Punjab, where the arms are typically twice the size of anybody else in the nation. And I'm not joking about that. So honestly speaking, you have to have that. The arms have to be at the level of the heart. And then you actually do these readings. You make sure that when you do these readings, they should be recorded in both arms at the same time, please. Not left first, then right. You do a series of recordings at 1 minute intervals. And it is recommended to make the measurements until variations between consecutive readings fall within 10 mm of mercury. You don't use the mercury barometer, you use the aneroid ones, the electronic ones. That's the one you're supposed to use. And then you get 2 readings from the right and 2 readings from the left, and that's the best way to do it. And you don't even have to work out the average. You just put this into the software calculates it. It's a complicated calculation. And the formula for that is the diastolic BP plus the difference between the systolic minus diastolic divided by 3. I won't waste time on mathematics. The machine does this for you. This is the way we're supposed to do it. You and me have to give a left mean reading and a right reading, and then it works out perfectly. And then analytes. We learned this a long time ago. We learned it first from the second trimester analytes that yes, high alpha fetoprotein was something that we had to be careful of as a marker of poor placental function, high HCG, and a high dimeric inhibin A. We also learned that a low PAP-A was an indicator of poor placental function. And we worked on this, and we worked on this, and we worked on this. And we realized that, yes, now we have a combination that we have worked on, and see how well this works. This is old work. This is work that is now almost 8-9 years old, but it applies even today. But the reason I put these factors here is to understand that people say, suppose I don't do this and I don't do this. Suppose I don't do mean arterial pressure and I use only uterine artery Doppler. If you do a suppose, and this and that, and you don't do Plgf, for instance, or you do only PAP-A, things are going to go wrong. Your detection rate is not going to be as good. Then what's the point in doing something that's halfway home? Try and do the whole thing. If you can't do the whole thing, counsel your patient. We spend so much on nonsensical things like family occasions, like festivities and things like that. Spend on health instead. It makes a lot more sense. You're going to get a baby without cerebral palsy. It makes complete sense. So if I do everything, I really get a very, very good detection rate if I use a cutoff rate of 10%. So if I accept a false positive rate of 10%, I get a 96% or even a 99% detection rate. If I skip out on all of this and I do only biochemistry, and I use only PAP and I don't use PAP and I don't use Plgf, I'm losing a lot of information. If I want to hit the hundreds, and this is a later chart compared to this one, then I must put everything in there and try and hit 100. That's the right way to go about it. Not by saying, suppose I do this and suppose I don't do that. Your figures will go from 100 down to 88, and they might even be as low as 71. And if you're not watching any of that and you say, no, my uterine artery is not so good, and my patient can only afford PAP-A, then you may as well toss a coin and try and figure out what's going on, because that's only a 50%, 55% detection rate. So please don't ask me that question when we reach the end of this story. The next thing is, so you have a risk, and then what do? You give aspirin, and we proved it again and again and again. A beautiful way to learn this was a paper in 2019 from the Nicolaides group, which tells us that the administration of 150 milligrams of aspirin, or anything more than at least 100 milligrams, because that's where we hit the aspirin resistance, will delay the onset of preterm preeclampsia to many, many weeks. So you can postpone a 28-weeker to a 35, and similarly, you can postpone the 36 weeks to absolutely end of pregnancy, which is so marvelous. The best way to calculate the dose is something we learned from our heart patients, our cardiology patients in 1979, which is 2.4 mg per kg, and give it accordingly, give it at night. And then a question that always brings up a doubt. If my patient comes to me after 16 weeks, what do I do? Controversial literature, but in general acceptable, that although the effect is not as dramatic as I've shown here on this chart, if you do start later, in general, maternal and fetal morbidity is reduced by 10%. So there's no harm in starting a little later, but please give it at night and make sure that the patient is compliant. Compliance is extremely important. It's taken us 20 years of research, most of it led by Kypros Nicolaides, to try and figure out what are the right biomarkers of preeclampsia. At 12 weeks, we use mean arterial pressure, uterine artery PI, and PLGF. The correct way, and not call it luxury, at 22 weeks is mean arterial pressure, uterine artery PI, PLGF, and SFLT1. SFLT incidentally stands for soluble FMS like tyrosine kinase 1. And you use exactly the same formula at 32 weeks, and you skip the uterine artery in the 36-week calculation. Basically, this PLGF is an angiogenic protein. It's synthesized by the syncytial trophoblast. And we do understand that the lower the level, the worse the amount of placenta. We do understand that it is a great predictor of placental function. The same thing is SFLT, that the moment you start getting altered levels of SFLT, then you know you're in trouble. We learned a long time ago that we can work out a ratio between SFLT and PLGF, and 38 seemed to be a reasonable cutoff. 38 and less, you were very, very comfortable, and we will discuss this kind of a chart further. And beyond 85 is really bad outcomes, and 38 to 85 were the mild outcomes. Remember, we now have P divided only into mild and severe. This is mainly for the non-clinicians who are on board tonight. So we realized that the misdiagnosis of preeclampsia, when we add on this as we go through pregnancy, particularly screening between 22 and 24 weeks, will reduce the misdiagnosis of preeclampsia and improve the prediction of adverse pregnancy outcomes. That is something that you and me really need to consider. Now, a lot of other things have also been worked on, PP13, VEGF, etc., but the one that's clinically ready is PLGF and SFLT1. The next thing is screening for preeclampsia. Of course, we will do it for people who miss their first trimester, but it's also now part of routine evaluation. For convenience, we do it at the time of the 18 to 20 week scan. And this is because we want to stratify how we're going to care for these women. Ideally, if that is still high and the uterine artery doesn't work out right, you will repeat this at about 23 to 24 weeks. And you don't have to repeat an anomaly scan at that time. You just do the uterine artery, do mean arterial pressure, put it all in, do a biochemistry and find out the new risk, and you will get your answer and reduce the risk of everything that has happened. If you have a largely unilaterally located placenta, you will find very discrepant PIs. Again, the mean PI is still to be used. So if you have a left-sided placenta and an awful looking PI on the right side because there's no placental tissue there, you will still use the mean PI, and that's the way to go about it. What do we do beyond this 22 weeks window is that we actually go through a situation where we use a ready-made software which is free of cost from the Fetal Medicine Foundation. This is how you go for it. You Google the Fetal Medicine Foundation and you will get these menus. And in that, when you click downwards, calculators, you go to risk for preeclampsia. You record whether it's singleton or twin, gestational age. You put in your date, you put in maternal characteristics, which include date of birth, height and weight, racial origin, smoking during pregnancy, whether the mother had preeclampsia, and the method of conception, whether spontaneous or IVF, and then a medical history, chronic hypertension, diabetes 1, diabetes 2, SLE, antiphospholipid syndrome, whether she's nulliparous or parous. Then you put in your mean arterial pressure, your mean uterine artery PI, the date of measurement, and then you will put in the biochemistry. Remember, if you don't have any of these, you can put in a no, but then your results of predictability are not so perfect. Then you press calculate and you get the answer. If you've done the course, you get this free download. Even if you haven't done the course, very often you're lucky and you get a free download. Now, what is this business of going on at 19 to 25 weeks? This is new. So those of you who like to take screenshots, this is good because this is a good summary of what's going on. You see, again, at 19 to 25 weeks, you have to rescreen because you want to develop a method of surveillance for the rest of pregnancy and divide patients into a high risk group, an intermediate risk group, and a low risk group. So screening at this stage should ideally be, again, a combination of maternal factors, uterine artery PI, mean arterial pressure, and serum Plgf. And the risk of PE at less than 32 weeks and less than 36 weeks should be calculated. On the basis of these, you then put them into the 3 management groups. The high risk group would require close monitoring for high blood pressure and proteinuria very frequently between 24 and 31 weeks, and I will show you a chart for that. The intermediate risk group, along with all the undelivered pregnancies from the high risk group, would have a reassessment at 32 weeks to find out the ones that need more monitoring from 32 weeks onwards. And now see how well this works. At a risk cutoff of 1 in 25 for P less than 32 weeks, 1% of the population will be stratified into the high risk group, and it will continually all those cases which will develop preeclampsia at less than 32 weeks. And these patients then would need close monitoring at 24 to 31 weeks, the ones that are identified as high risk. At a risk cutoff of 1 in 250 for preeclampsia, less than 36 weeks, 10% of the population will be stratified into the intermediate risk group, and this will contain 90% of cases that will develop preeclampsia. So it's a very great safety net. These patients then need reassessment at 32 weeks. So it is very, very clearly telling you instructions, and these instructions, believe me, are available within that software, etc. And then irrespective of which group they are, the high, the low, or the intermediate, all pregnancies are to be reassessed at 36 weeks to define the high-risk group for term pre-eclampsia. Remember that we have the prognosis study, which was published in 2016, that told us about the advantage of SFLT and its ratio with Plgf in women with suspected preeclampsia. It was the first multi-center, huge sample study to demonstrate the prognostic value of this test and those women that are likely to develop preeclampsia in the coming few weeks. The moment we do that and we add this measurement to proteinuria, blood pressure measures, then you can reduce hospitalization, pre-diagnosis by 50%, which is fantastic because in terms of economy, that truly works well. Now, this is how it works, that if you use that cutoff point of 38 for the SFLT PLGF ratio, then it tells you that within 1 week, you will have like a rule out, which works out fantastically, of almost 99% of women who will not develop it. And it has a great positive but predictive value as well, which is specific. And that tells you that, yes, within 4 weeks, these women might require attention. So you call them back more frequently. But the ability to send people home and reassure them is something which is absolutely fantastic. And this is that chart that came out last year. It was in an opinion by Leona Poon in the White Journal in one of the earlier issues last year. And it says that in the first trimester screen, we will have all pregnant women and assess maternal risk factors, mean arterial pressure, uterine artery PI, PLGF, and PAPA. And we will make sure that we do a PLGF because currently speaking, we actually have PLGF incorporated into a lot of software that gives us PLGF much cheaper. The problem with PLGF is that when we do it in bulk, we're quite happy and the cost works out right. If you do it individually, it doesn't work out so well. So if you're willing to wait a few days, which I don't think there should be any harm, you put in an entire batch and then PLGF works out well. If they come into low risk, then they don't need aspirin. And if they go into high risk, they need aspirin. And then you leave them alone. And then they come back at the time of the anomaly scan. For the low risk, you then do an algorithm that includes abnormal uterine artery and see that if the Doppler is greater than 95th centile, then you reclassify them as high risk. And then they go into this pattern again. For the high risk, you repeat everything in the second trimester scan, the mid-trimester scan, and then you say, okay, what do we do next? We stratify them into low, intermediate, and high, like I explained. And you can do this by using one of two methods. One, of course, was the FFF algorithm, in which you have the option of not using SFLT or PLGF. And the other one is when you use it and you add it on, and you measure that somewhere around 24 weeks or so. So in this situation, then again, you have that ability to follow up, and that is how you do it. If they come to a low risk at the time of this mid-trimester anomaly scan, then all they need to do is to come back at 36 weeks and you're very, very comfortable. And remember that if you're adding on SFLT PLGF ratio, this would be the group that has a ratio less than or equal to 38, and you can then put them back into standard clinical surveillance. Then you have this group, which is the high risk. And in the FMF algorithm, it tells you, look, if you have a high level risk, then you really put in high level surveillance with a weekly clinical assessment of blood pressure and proteinuria and home BP monitoring at 24 to 31 weeks. And of course, the same thing applies in exactly the same way if you have an SFLT PLGF ratio greater than 85. In the intermediate risk, in the FMF algorithm, then you reassess them at between 30 and 34 weeks, and then again at 36. And the same thing, but usually if you're using SFLT and PLGF and you're between 38 and 85, you're very, very comfortable and you don't have to worry too much about them. It seems to help a lot. Now, the moment you have a clinical suspicion of preeclampsia after 24 weeks, and the SFLT PLGF ratio is less than 38, the progression within 1 week is unlikely, like I said. And if it is greater than 38, it's might progress within 4 weeks, and therefore then you will bring them in and you will do a surveillance and you will look for a deteriorating maternal condition, and of course do a complete full evaluation for that fetus and make sure that you don't miss them. Moving to the last two sections, preeclampsia in twin pregnancies. You have to use twin-specific reference ranges because of the increased placental mass for your uterine artery Doppler. But remember that there's a very high screen positive yield in this simply because you have so much placental tissue. And therefore, you have like a 75% screen positive, but that's completely acceptable. Anyway, most of them are on 75 milligrams because of their fertility treatments. You just expand that to 150 milligrams. But it's completely acceptable to say that, yes, there's a 75% screen positive. Now, what about the rest of us, where we handle a population that may not be able to afford this, or we're working in a government institution which has limitations, or we're working in charitable institutions which have limitations? FIGO recommends that you take maternal characteristics, mean arterial pressure, and follow up with albuminuria, maternal weight gain, and edema. And whenever you have a suspicion there, you refer to tertiary care and counseling, where then they will get accelerated care. So this is the compromise situation. We have something new coming up in India. The organization Gestosis has taken over this. And we have some excellent work from Dr. Sanjay Gupte, Dr. Pandit, and Dr. Girja. And they have told us that there is a nice Gestosis score. And the validation is awaited, which I think will happen halfway through this year. And this is how they calculate a Gestosis score. You have a bunch of things that you can tick off, and you don't have to necessarily do this yourself. You can train your clinic staff to do this. And then you say, okay, if you had a woman born small for gestational age, or she's older than 40 or younger than 20, she has a BMI greater than about 26 to 30, she's nulliparous, she has family history, PCO, blah, 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 all the way down, including gestational diabetes and inherited thrombophilias, then you give a score. And based on that score, then you can suggest to them what would be best for them. The other thing is two new things. One is late screening for preeclampsia, and we will discuss this with Dr. Aparna Sharma, who's one of our panelists tonight, who is going to be undertaking a great piece of research on behalf of the Society of Fetal Medicine to tell us that, yes, there is something more to this. And what is that? It's Congo red. Congo red is a chemical that binds to misfolded proteins. And misfolded proteins is what you find in the urine of women with preeclampsia and with a prediction or predilection for preeclampsia. Now, what happens is that you put this in and you learn to recognize these patterns on a sheet. and you have your answer. So basically, you have this membrane on which urine contains the misfolded proteins, and you get these and you say, okay. And we will discuss this. And this seems to be the future, because you have people walking into an OPD and you can discuss this. You have people who walked in with no previous evaluation, and you can then discuss this and offer it to them. And we do hope that the manufacturers of this will make it available cheaply by the end of the year. So a good preview during our section. Then we have something that we came up with from India many years ago, but it was a project ahead of its time and therefore went on to the back burner, and now everybody's woken up to it. And this was a paper presented by our group about 8 years ago on 3D and 3D powered Doppler evaluation of the placenta at 11 to 13 weeks, 6 days. And we combined that with a low PAPA as a predictor of adverse pregnancy outcome. What we did was a fixed setting for acquiring these in terms of machine settings. And we had a very small series, only 38 patients at that time. And we said, okay, we will do a 3D, we will do a vocal of the placenta. And with that vocal of the placenta, we would calculate the 3D indices and put that all together. And we said, yes, we developed a chart and said, okay, this is a for placenta and a predictor for preeclampsia, for fetal growth restriction, for placental abruption, and for one or two other conditions which are still developing. The problem with this is that it cannot be recommended for population screening because although it was a very well done piece of research, it requires high-end equipment and takes a lot of time. So for general screening, not yet acceptable, but we do hope with automation coming along in the next few years that, or maybe in a year, next year or two, that this will be very much possible. The newest kid on the block is ophthalmic artery Doppler, and Dr. TL Praveen will discuss this in detail with us during the panel discussion. And there we are going to show you how to do an ophthalmic artery Doppler, how we don't use a first peak systolic velocity or a second one. We use a ratio of those two, and women who are at risk will have a higher second peak systolic velocity. You can you use it in both eyes, and we will discuss that, and you take a mean, and we will discuss the technique. But the important thing is that it actually improves the prediction of preeclampsia at all times. In your initial formula at 19 to 23 weeks, as well as at 37 weeks. And you can actually say, yes, this is something that works, because we have 2 excellent papers that have come out, particularly for the 36 weeks window. We also have the possibility of assessing maternal cardiac function with ultrasound and come up with some smart things. Again, this is work under progress, work in progress, and we'll talk about more next year, perhaps. For now, we believe that this is the formula we need to be working, and perhaps adding on to this ophthalmic artery Doppler, which is maternal characteristics, uterine artery Doppler, mean arterial pressure, PAPA, and PLGF. And remember that uterine artery Doppler alone is not as good as all the factors together. And thank you so much for your attention here. I will now stop sharing my screen, and we will go on to the rest of the actual program, which will be part of a panel discussion where we will take on from where we've left off here, and we will go through this. And please do get your questions coming in. We have very few questions as yet. And we would really like to answer those as we go along. So please keep these questions coming in. And meanwhile, let's hear what our trade partners. And so welcome back. We will now move on to showing you how nicely we can work on what you've just heard, the practical aspects. And we have a very illustrious panel tonight. They don't really need an introduction. People at the Society of Fetal Medicine know that these are household names. We have Dr. TL Praveen, our president. For those of you who are new to him, and I know we have almost 1,000 new members in the last 1 year. Dr. TL Praveen has a practice in Hyderabad, has been working with ultrasound since 3000 BC, and is one of the greatest names to ever contend with. We have Dr. Chinmay Rath, who is also from Hyderabad. and has a background in obstetrics and gynecology, fetal medicine. She is, again, an extremely well-known name. She is known for throwing at you how you should be handling your patients correctly. She also teaches you values which we tend to forget, which is that the patient is a human being and needs counseling. And I look forward to her inputs on this as well as the technical aspects. We have Dr. Parna Sharma, who has a completely tricky mind of looking at things where she always seems to find solutions where you can only think of problems. Thank you, Aparna, for all the wonderful work you're doing as part of our executive committee at the Central SFM and for initiating things. I'll also expect you to tell us a lot more about Congo Red. And we have Dr. Krishna Gopal. Dr. Krishna Gopal is our dynamic National Executive Secretary and has been responsible for taking you from A to Z in terms of the administration that's going on and at the central office. And so let's start first. We'll start with the ophthalmic artery because it seems to be the answer in terms of what is going on in India. And that is that we do understand that we have cheap ultrasound services, that we have cheap, good ultrasound services. And here we have a cheap, good, incorporated way of assessing ophthalmic artery Doppler. And that by itself, and when added on, it enhances our prediction and sensitivity for preeclampsia, particularly towards the end of pregnancy. So it's a well-tried trick at 36 weeks, and it's really marvelous. And perhaps it is the answer to people who think that SFLT PLGF ratios might be too expensive. And but first, Dr. TL Praveen, if you could do your slide share and tell us all about the maternal ophthalmic artery Doppler.
Thank you, Ashok. Thank you for the introduction that as if as I'm a fossil. Good. And then today we are going to talk to you on ophthalmic artery Doppler in preeclampsia. As it has been very clearly mentioned by Dr. Ashok, that ophthalmic artery is a simple, accurate, and an objective technique with a high predictive value in the detection of all types of preeclampsia. Now, ophthalmic artery Doppler changes are basically due to maternal hemodynamic adaptation to pregnancy, and they are not due to trophoblastic invasion. This is one important pathophysiology that we need to understand the implications of ophthalmic artery Doppler. Now, basically, when you start sampling the ophthalmic artery, the factors which we consider are most often the pulsatility index, peak systolic velocity, and the ratio, that is the PR ratio or the peak systolic velocity ratio. If it is more than 0.99 in a preeclampsia, it can identify women at increased risk of adverse maternal outcome and pregnancies at greater risk of preterm birth. So this is one of the most important factors that we need to keep in mind while evaluating these patients with the possibility of a preeclampsia. Now, how are we going to go about it? The interrogation of the ophthalmic artery is basically you make the patient lie down supine as you are doing your antenatal scan. And at the same time, the eyes are closed and a conduction gel is applied on the upper eyelid. A linear transducer, probably if not 9L, any linear transducer with a little higher frequency because you are trying to evaluate a small parts, then we need a higher frequency. A transducer is placed transversely across the upper eyelid. The right ophthalmic artery is the one which is quite often assessed because it is much more convenient for a right-hander. But of course, like people like Chinmay, probably the left eye, they would like to scan. And then the transducer moved craniocaudally without exerting pressure on the orbit or the eyeball. And then the ophthalmic artery is identified and sampled about 15 millimeters from the optic disc, which is usually to the medial of the optic nerve. And the angle of inclination, it should be less than 20 degrees. We don't need to really worry about the filters, but the PRF is extremely important that it should be 125 kilohertz. So these are the factors that you need to keep in mind because this is a simple technique, but if it is done properly, as you can see here, this is the way you make the patient lie down, then supine, ask the patient to close her eyes, and at the same time you apply the coupling gel or the conduction gel over the upper eyelid and use the transducer. And as your transducer is used, you can evaluate the orbit as well as you can see the optic nerve as well as the ophthalmic artery. So once you sample them, these are the things that we get. That is the first peak systolic velocity. Later on, we have the second peak systolic velocity, which is also called as first diastolic systole, and then diastolic peak. And then we have the pulsatility index, and we can calculate the PSV ratio. Now, there is a lot of evidence that has been there, which is suggesting that the pregnancies with PE, that is the preeclampsia, there is a decrease in the impedance. This is an extremely important statement that one should understand to understand the application of ophthalmic artery Doppler in evaluating preeclampsia, because it decreases the impedance of flow and it increases the flow velocity. So this is one thing which clinches the crux of the matter, which can help us to diagnose preeclampsia at all terms. So this is a classical example where you try to use a linear transducer, keep it on the upper eyelid, and then once you start examining and put the color Doppler on, that black area is the optic nerve, and then adjacent to it on the medial side, you find this ophthalmic artery. And once you identify the ophthalmic artery, you can place your Doppler gate or the sample gate over the ophthalmic artery about 1.5, that is 15 millimeters from the optic disc. So that is where you have to take the sample. Once that is done, then the PI and RI are automatically calculated because of the autocal, and then we can calculate the peak systolic velocity. And most important thing is, this is a typical peak that you see, where you can see the peak systolic velocity. Then the next peak is basically called as the second peak, or you can also call it as first diastolic peak velocity, and then the ejection, early end diastolic phase. So based on these parameters, we can calculate the peak ratio or the peak velocity, systolic velocity ratio, which is PDI, that is the first diastolic peak velocity by the peak systolic velocity. And this PV ratio is significantly increased in preeclampsia. So this is the basic understanding that we need to have when using this for our. So the spectral waveform typically appears like this, where you have the peak systolic velocity and you have the first diastolic peak and then the end diastolic. So these are the three components that we have. And once we have it, is then the first, the most important thing, and the data which is used to interpret these findings is that the first diastolic peak, that is the PDI or PD1, is 24.56 centimeters per second. You can take a snapshot of this, because peak ratio or the peak systolic velocity ratio of more than 0.60 increase the risk of all types of preeclampsia. This has been correlated with the uterine artery Doppler, where you can see that when you take the controls, where you do the ophthalmic artery sampling, it is usually about 20 centimeters per second, whereas in all PE, it is more than 20, that is about 24 centimeters per second. Whereas if you take the uterine artery Doppler, the controls show that it is less than 40, whereas the early PE, that is the early preeclampsia, where you get about 60 to 65 centimeters per second. So this is how you are going to correlate with the uterine artery. Not only that, the correlation is also much more evident that the ophthalmic artery is more useful in predicting the preeclampsia in all preeclampsias. So as you can see here, the PD1 is almost persistently more than 24 in all types of preeclampsia. The PR or the PSV ratio is also more than 60 in all preeclampsias. So these are the aspects that we need to know. And as you can see in case 1, we have a uterine artery Doppler, which shows that the PI is 2.32. The mom's wise, it is definitely increased, and it indicates that there is an increased resistance. And you do the ophthalmic artery, you can see that the PSV ratio is 0.80, and the second peak, that is this one, is almost about 25.85 centimeters per second. So this is for, there's another case where we can also see that this is the uterine artery which has been sampled, and this is the ophthalmic artery which is sampled. And here the second peak, that is the peak diastole, first peak diastole, is almost about 27.11 centimeters per second. So this is an extremely important tool which we can make use, and this is very simple, and you can start practicing on your day-to-day cases. where not only do the uterine artery sample, if suppose in case if it is difficult to achieve uterine artery Doppler, you can always do this ophthalmic artery sampling, and that gives you, that improves the detection rates and the PSV ratio, improve the prediction of preterm and term PE. When this ophthalmic artery PSV ratio, along with maternal factors, mean arterial pressures, as well as the uterine artery PI, Plgf, and S-FLIT1 remarkably improved the detections of all types of PA. So with this, I think now we know very clearly that ophthalmic artery Doppler is an extremely important tool in evaluating preeclampsia. Thank you very much.
Thanks, Praveen. That was extremely useful. And I'm so glad we finally have a tutorial to show everyone that, yes, we have this beautiful artery that we can see. You can use a 9 megahertz linear, which we often have. Otherwise, you can even comfortably use maybe the 11 megahertz. If you have a 7, that's a little easier. That we have an ophthalmic artery that is superior and medial to the center of the eye, and that you can sample. Some papers say left and right, and you take 2 from the left and 2 from the right. And some papers say you can take a single one and use the right one. I guess in the beginning, it's nice to get used to this. And so it's a good idea to do 4 on each. And then we go ahead. So thanks so much for that. And we will come back to more questions as we go along. But before we take this marvelous question box, there's this one question that bugs me, because everybody loves to ask this question. It has such a nice, straightforward answer. But we love to twist the question and the answer, and it is this. And this is from Dr. Rekha Maratha. In a patient who's at risk to develop PIH in the present pregnancy, with a present BP at 8 weeks at 130/90, and she's on low-dose aspirin, she bleeds. So we stop the aspirin, but she bleeds again on starting after a gap of 7 days. What do I do? Dr. Chinmay, please.
Thank you. Thank you very much, sir, for the question. Thank you, Dr. Rekha, because it's a very, very practical problem for most obstetricians. Now, the thing is, she has a BP of 130/90 at 8 weeks. So is she a patient of chronic hypertension? Because preeclampsia technically would not set in so early. So it cannot be a pregnancy-related pathology, which is related to her high blood pressure. And if she's already hypertensive, is she on hypertensive medications for that? And that needs to be controlled. So giving her aspirin at 8 weeks was based on which kind of screening. We need to revise that, because 8 weeks, we would not have had a proper preeclampsia screen by that time. So she may be on aspirin for some pregnancy-related issues like fertility or something like that. And therefore, you need to assess the actual requirement of the aspirin at that point. If she is bleeding, yes, you have to stop the aspirin, get a BTCT done, check what is her condition. I mean, because their aspirin is not your solution. So you have to stop it. Stop the aspirin. If she doesn't bleed anymore, that means only aspirin was the culprit. Otherwise, she could be bleeding because of hormonal imbalance. She could be bleeding for some other reason that her pregnancy is not set in there. And even if you stop the aspirin, the bleeding might continue. So let this pregnancy go on till 12 weeks without any further intervention. At 12 weeks, get a uterine artery Doppler done. Look at all the other parameters. If the baby is growing properly, look at the PAPE and the PLGF at that point. Reassess the risk of preeclampsia, and then we will reconsider the aspirin at that point if necessary.
Thank you. And Dr. Aparna Sharma, your inputs, please, on this approach of blaming aspirin for the bleeding.
So, sir, I would agree with Dr. Chinmay in most situations. Yes, I mean, and we really have to look at it like, if she's obviously on aspirin, assess whether she needs aspirin in the first place. Yes. And she's on aspirin, she's bleeding. Yes, you would stop aspirin for some time. And if she stopped bleeding, then reassess the risk. And if she requires aspirin, restart the aspirin. See, the first thing is that aspirin does decrease the risk of a recurrent preeclampsia, or, so aspirin is an important drug. So please reassess the risk and the need, if it is required, because not all bleeding is because of aspirin. So we really need to understand whether the bleeding is because of that or not. And if it has stopped, then please do reassess the risk and restart the aspirin if it is required, because we know that aspirin works. So do not stop aspirin unless we are sure that, that this bleeding is happening only because of aspirin. Like as Dr. Chinmay said, there could be other reasons for the bleeding. But if it has stopped now, wait for some time and restart aspirin. This is what we normally do, and this is what should be done.
And can I confuse the matter further by saying that some people feel that in chronic hypertensives, aspirin may not work for preeclampsia?
Why?
Why?
I want to ask the question why,
No,
but there's absolutely crazy paper which has come in from no less than our good friend Kipros Nicolaides, who says that we're not sure it works. And you look at the statistics and it reduces the risk of preeclampsia by 36%. And to me, that is good enough.
yes.
No, sir. I think what that means to say is if there is chronic hypertension, there's a pathology already in-house, and then there is pregnancy on top of it. So whatever you do to reduce the risk reduction will not be as good as it would be in a case where there is no chronic hypertension in the background.
Yes.
So it may not work as well. Sorry?
So my next step of thinking is it may not work as well, but it still might work. So I still
might work because, sir, in the first trimester screening protocol, they have, assessment, they have used the parameter of chronic hypertension, yes or no.
Absolutely. So irrespective of whether it has a marvelous effect, we should still use it even if it has a 10 to a 36% effect. Yeah. So that brings us to one more question. And that is, why not start low-dose aspirin for everyone? Dr. Parna, please.
So, yes. So in the first place, aspirin is not a placebo. Aspirin has some side effects. And that brings us to a very interesting study which has been published in American Journal of Obs-Gynae in 2021. And they actually looked at 3 lakh women, and they said that aspirin, if given, actually increase the risk of intrapartum and postpartum hemorrhage and postpartum hematomas. So you see, aspirin is not a drug which is without complications. So we cannot start any drug without, its own side effects. So there is absolutely no confusion that we cannot start aspirin for everybody. So we have to think a lot before we start aspirin. So we have to do a risk scoring, and at least a history-based assessment is required for everybody. And I think if you want, I can share the link for that study, which is the latest evidence on a huge number of women. So that is the most recent evidence. But we also know that there are a lot of other problems with aspirin, including maternal risk factors, fetal effects, and maternal effects. But this is the most recent evidence which is available on aspirin.
Wonderful. Thank you for that. So if you could please share the link in the chat box. This question is for Dr. Chinmay. And this is that in patients, what is the cost of PLGF combined with PAPE? How much does the cost go up?
In terms of rupees, the cost will go up. But if you look at the ability to prevent the cost of a preterm cesarean section, a preterm NICU care, and the cost of caring for a child who may have problems with regard to all this, and the obstetric cost in future pregnancies because of a preterm cesarean section, I would think it is not that costly, because it gives us a better risk assessment. Now, just like Dr. Aparna was saying right now, giving aspirin to everybody sounds very good, but when you give it to everybody and somebody has bleeding and that person stops the aspirin, you don't even know whether that one was a high risk or low risk who stopped it. If somebody does not comply, you don't know whether that person actually needed that compliance because you've not done a risk assessment. So that would be very, very empirical. Similarly here, if we add the PLGF, we'll be able to pick up the true high-risk group which needs an intervention like aspirin. So in terms of cost, actually, when this PLGF got incorporated, the labs were very kind because they wanted to run this, and they gave us huge discounts, and they very nominally increased the price from the existing first trimester screening module. Even now, they are prepared. If, like sir said in his talk, if we have volumes, then it's easier for them also to support us in terms of cost. So if we give them a large number of samples, they are happy to bring down the cost and make it affordable for the patient. So it's not a very significant increase in terms of the price, But whenever we look at these things, that the cost, I mean, what are we comparing it with? If you can save one child from dying in utero or being born preterm unnecessarily, or a mother going into high HDU unnecessarily, I think the cost is justified.
Absolutely true. We have to get our priorities correct. And I'm so glad you agree with this, because there was this question towards the end of the talk that I was giving, and Dr. Munisai Sandhya said, how to screen in government settings. And we did give a model.
The government has to understand. And today afternoon, we had a panel on hemoglobinopathies and the same questions again. The point is, when there is a health burden on the society, the biggest affected party is the government, because you're actually affecting population. So if there is a condition which affects 3 to 10% of your pregnant population, which can lead to so much perinatal morbidity and mortality, the government better take care.
True, absolutely true. And now, how do you counsel these patients? When you're doing your counseling for patients in the beginning, you're counseling them about Down syndrome. How do you add a word on preeclampsia screening?
Till now, we've not found it difficult, because in fact, it's become easier to counsel for preeclampsia, because our patients even accepted Down syndrome screening. And the incidence of Down syndrome was 1 in 1,000 in the population, whereas the incidence of preeclampsia is 3 in 100. So, or 10 in 100 if I go liberally. So when we tell them this, that adding one more factor improves the risk profile for this. And fortunately, the labs give us a good deal on that. All of our patients have said yes.
Absolutely. Dr. Aparna Sharma, your experience on this?
So I would like to add to that question about the government setup. I work in a government setup, although
Yes.
I'm not a very high load government setup. But I must say that, a government setup is a myth. I always say that, it's all about, the quality that we, really we have to strive to change. It's all about history taking also. We did a quality improvement study, and we tried to figure out, are we actually taking the history? And that's not a difficult thing. Let us just begin by taking a history. We'll come to the biochemistry later, and we are moving towards aneuploidy screening. Somewhere we will move to preeclampsia. Let us start thinking, but let's start with a good historical screening for preeclampsia. That will solve at least 50% of the detection rate. Let us reach to that level in a government setup, and that should be the approach for government setup. Even, sir, you showed the gestosis screening protocol. Can we do that why can't we do that in a government setup? I don't think that's a very difficult thing to do. That's a very practical aspect, and that's just history based screening. So I think biochemical markers is the next best thing to do, but a historical approach is very, very feasible and possible. And as far as taking a mean arterial pressure is concerned, everything is automated now. You just put your systolic and diastolic blood pressure in your phone, and it gives you a mean arterial pressure. You don't have to do any calculation. So I think it's very feasible, and we are doing it every day in our practice. So it's just your practice. We use our phones day in and day out. So it's about habit, and I think it's what we do, what we want to do. So if we start thinking, then only things will change. So this is what I feel. Even for a government setup, it's quite possible to do.
Excellent. I wanted to ask Dr. Krishna Gopal, you handle a mixed population. You handle a population that firmly believes that destiny will work everything out very nicely. You also handle a fair degree of people who come from a more civilized, if I may use that word, section of society. How do you handle various aspects of this? And then there are a lot of your patients who want packages. They love to come under one roof and do everything. So how do you handle preeclampsia screening when a patient comes to you for an 11 to 14 weeks referral? You have to unmute yourself, Krishna. Krishna, you have to unmute yourself. We're not able to hear you.
Yeah. Now,
yeah.
But it's fine. Yeah. So I think that what Dr. Aparna has told, that goes true. We have to basically thrive to do better, and we have to at least goes and add one more things always. So or when you take the history, when you are doing your ultrasound, and when you are actually using in all these populations, people accept it. You have to make them accept what are the implications of it. Like I use one example that you gave once in your talk 3-4 years back, that you spend so much money in your first birthday of the child, and if you cut even one sweet from that, then you can afford for whole of the investigations. So basically it is a mindset of the people that need to be changed also. Basically we have to make them understand that if they give somebody who are giving them just blessings 5,000 rupees after their birth of the child, then they can spend some money upon their their
Yes.
investigations. So basically it is a mindset that need to be changed.
Thanks so much for that input. We have now a specific question for a clinical scenario. And this is that in a patient with a high risk for aneuploidy in first trimester who decides on invasive testing, the uterine artery PI is normal, does a double marker still hold a place? Dr. Aparna, please.
So basically here what we have to understand is that if she's going if she's undergoing invasive testing for aneuploidy,
Yeah.
right? So if she's, so that part is definitely ruled out, right? So we are not going to do anything, and uterine artery Doppler is normal. So it's all about numbers right here. Now, what extra are you going to gain by doing a dual marker, right? So here dual marker has two things, PAP A and beta HCG. Now, beta HCG doesn't really predict preeclampsia, not very effectively. PAP A can add to your preeclampsia screening by little bit, and it can also help in prediction of fetal growth restriction, a bit of it. Now, so what are you actually gaining by doing a dual marker? That is what you have to see. So if somebody has decided to go for invasive testing, I would first like to know why she has decided to go for invasive testing, on what basis. Was it a previous history of Down syndrome, and she really wants a definitive diagnosis, she doesn't want to go for NIPT? So that is the first question that I would like to know, on if she has decided to go for an invasive testing. Over and above, a dual screening really will not add too much of an importance to her tests.
But is there still a role of doing PAP A and PLGF as pre-eclampsia screening?
So that is what it is. So as a pre-eclampsia screening, normally dual screening has PAP A and HCG. HCG, it does not have a lot of detection rate in terms of pre-eclampsia. PAP A, in terms of pre-eclampsia screening, if you want to combine the other markers, PAP A will improve the detection rate quite marginally. If you are able to add PLGF to it, definitely it has an importance in pre-eclampsia screening. But a dual screening, a traditional dual screening, will not have PLGF. So you will have to ask for an additional PLGF if you want to look for specifically pre-eclampsia screening in the first trimester. So if you're wanting to go for a pre-eclampsia screening, please ask for a specific markers for pre-eclampsia screening. That is what you would want to look for. So do not confuse an aneuploidy screening with pre-eclampsia screening. If you want to look for pre-eclampsia screening and you are able to afford it, please go for a combined markers of PLGF and not just rely on just PAP A and beta HCG. That is what I would like to say.
Yes. So once we show that this thick nuchal translucency was not for other reasons, we do need to address this as well. Also because it is possible that there might be other factors in her history that might need attention. So I guess that we have to really cater to every individual at a personal level and then give that personalized risk on that basis. There's no doubt that PLGF is available also as a single analyte, and we can use it in the FMF software. Now this question is for Dr. Chinmay. Where at a particular gestational age between 11 weeks, 0 days and 13 weeks, 6 days, should we do PAP A and PLGF, or can we do it at any time in this window?
Well, you can do it at any time in this window. If you have a choice, you could do the biochemistry a little early on and call her for a scan a little later. It actually is very rational to do that because you will have the biochemistry results with you and you would have finished the scan and then given a complete combined report at the same time. but it's sometimes difficult in settings where the patients don't come twice. They come to their obstetrician and then they take an appointment for a scan and they arrive. So you don't have the facility of having an early biochemistry. Statistically, the biochemistry works better earlier on in gestation. The scan works better a little later in gestation because you see much more on the scan. So if you can do it separately, do the biochemistry towards 11 weeks and the scan towards 12.5 weeks. If you can't do it, then do everything together, but within that range.
Thank you. And Dr. Thiel Praveen, what do you think is the right age for the fetus to be assessed from an anatomical point of view? 64 millimeters should be used as a cutoff, or?
Yeah, 64. Usually about 12 weeks, 6 days is an ideal time when you would like to see for the structural abnormalities. So putting all together is better to call them around 12 weeks plus, so that you can do your biochemistry as well as nuclear transfers and also evaluate the structural anomalies, so that structural anatomy, so that one go you can finish off everything. I mean, that's how our system works.
Exactly. Dr. Parna, why do we give low-dose aspirin at night?
So basically, if you look at the function of aspirin, you have to see why we are trying to give aspirin in the first place. So the pharmacokinetics of aspirin as a COX-1 inhibitor, it has been seen that it functions better at night if you give the dose at night. So that is the effect which has been seen in various trials also. So the efficacy of aspirin is better when it is, as a pharmacokinetics has been seen that the efficacy is better when it is given. So basically it has two functions, but the action which is better seen as a prevention of preeclampsia is more as a COX-1 inhibitor, which has a better function which given at night. So it has been seen. So most of the trials do recommend giving it at night.
And plus we have that really old information about maximum vasospasm
occurring around
4 a.m. and 6 a.m.
2 a.m. or 4
effect, yes.
4 a.m. So with that kind of a diurnal variation, it really makes complete sense to have a nice big dose of this stuff. There's also a very interesting question on where to get twin specific reference curves for our cutoffs, and the twin specific reference curves are not necessary, simply because you just put it into the twin software and we get it automatically. So you don't really need the twin specific curve. There is a twin specific curve available from the Fetal Medicine Foundation publications. There's a very nice paper in 2014, another one in 2016, but you don't need it, we just pop it into the software. The question is, which lab does PLGF and PAP-A? I think everybody does now.
Everyone does now.
Yes, it's just a question of bargaining with them. There's no doubt that you can get some really good bargains by saying, okay, let's do a penta, and that is the cheapest way to get a PLGF done. But you can just do a double marker plus PLGF depending on what is offered to you. Now, Dr. Lakshmi Paluka wants to know, what is the cutoff to say high risk for preeclampsia in the FMF software?
Usually taken as 1 in 100.
1 in 100 for early preeclampsia, for preeclampsia which sets in before 34 weeks.
But yes, it's actually given in the software. If you have actually gone there and looked into it, you're not even, so they also suggest that you should be taking aspirin. So
it comes as a default.
Apply your mind at all. So they will give you the answer, what to do, what is the risk, what you should be doing, what is the risk for early, what is the risk for late. So you absolutely don't have to apply your brain at all.
Yes, and the same thing applies to the changed cutoff at 1 in 25 for the high risk when we do it later in pregnancy, SFLT. There's also this question on which lab does SFLT PLGF ratio and where to send the samples. For that reason, we got one of our trade partners today to really bully them into this, and they have now made it available. It was available only as part of projects before, but now it is going to be available, and we're still hammering them for the right price. Dr. Chinmay, have you been working on them for the price as well?
The price is not my forte, so that's yours completely. but yes, and again, the price will depend on the demand. So if we demand more, SFLT PLGF will still take a time, because as you mentioned in your talk, it's about just triaging for 1 week.
Yeah.
So not many settings will be actually able to afford that. There, even we have an affordability issue. But it's very useful if we start using it.
Absolutely. And then a very interesting question. At how many weeks is uterine artery PI record started? 6 to 7 weeks or 12 weeks after the aspirin evaluation? What they're referring to is the fact that very, very commonly, a lot of people who are doing IVF love doing progesterone or uterine artery flow and use that to guide aspirin, and they mix it up with the results of heparin analogs, for instance.
No, sir, but then there's a difference here. When we are doing uterine artery Dopplers in a non-pregnant uterus, as in for fertility treatment, that's a different assessment altogether. That's about blood flow to the endometrium and things like that, about implantation, about the pregnancy setting in. And there, if they start it so early and they recommend the 75 milligram ecosprin, that's justified because in the recurrent pregnancy loss guideline, it still is that recommendation.
Yeah.
What we are talking about is pre-eclampsia screening, which starts after some degree of placentation occurs. So you mentioned that the placentation occurs in 3 phases. I mean, 2 waves, major waves, and complete by 24 weeks. So we need to do that beforehand.
Yes.
So we need
No,
to do it
what some people tend to do is that in the pregnant patient, they want a uterine artery done every time they send for a heartbeat evaluation. And then they decide whether they're going to add on something else, such as a heparin analog, injectable and stuff like that. Is there any evidence to support that practice?
It's not based on the uterine artery evaluation, sir. It's based on an assessment of antiphospholipid antibody syndrome or some pre-existing thrombophilia, which is again a different assessment to be addressed by a different group of experts who deal with recurrent pregnancy loss and fertility.
And Dr. Aparna, would you agree completely?
So I completely agree with Dr. Chinmay. So here we are talking about 2 different issues. And I think, sir, there's one more question on that later on also. So let us just discuss here that there are 2 different entities here. So the issue of recurrent pregnancy loss, and the statement has been given like a blanket statement that in IVF, we start low molecular weight heparin and aspirin. So unless there is a high risk, IVF is not an indication to start low molecular weight heparin, number 1. So the indication to start low molecular weight heparin and aspirin is well-defined antiphospholipid antibody syndrome. Hereditary thrombophilias are not even, even those are not like very well-defined, because you really need to have an indication to test for them and then start treatment. So let us suppose that if a patient has antiphospholipid antibody syndrome, those are the situations in which you would start preconception aspirin and heparin as soon as pregnancy is confirmed. And in those, as Dr. Chinmay mentioned, the dose has been 75. Now, this 75 milligram dose has been tried and tested in various trials, and it has been shown to be effective. Now, let us not confuse here with preeclampsia prediction. Now, we know that preeclampsia is more common in antiphospholipid antibody syndrome. And if you go for a historical screening, history-based screening of preeclampsia, antiphospholipid antibody syndrome is a high risk factor for preeclampsia syndrome. Now, in a patient who's antiphospholipid antibody and you do a history-based screening and she turns out to be a high risk for preeclampsia, she would still require a 150 milligram of aspirin. Otherwise, she continues on 75 milligram of aspirin for antiphospholipid antibody syndrome. So let us be very clear on why we are giving aspirin, what is the background condition, and how do we continue taking aspirin in this pregnancy? What is the indication for giving low molecular weight heparin in this pregnancy, which is antiphospholipid antibody syndrome? IVF is not an indication for giving low molecular weight heparin.
Absolutely.
That is so nice and clear, and I'm so glad you clarified it in that many points. Thank you so much. We move on to our questions, and there is this question about the role of glycosylated fibronectin as a predictor for preeclampsia.
The test available, sir. There's a company which has a product, and it has been evaluated in some studies. They're not large. I don't know, Dr. Aparna. I don't think they're very large studies. There's some small supported studies.
Yes.
Not yet.
It's one of the options. So there are many ways of doing certain things. That's one of the options.
I don't think it is clinically available to.
There is, I think there's a test, Lumella or something. There's a test available, but not widely.
Is it a good tool? It's not an efficient enough tool to be used routinely, and the predictability is between 53 to 64%, which does not qualify as a good tool. In the future, perhaps. There's a question here, again, for our clinicians: what treatment available for raised SFLT PLGF ratio when we do a second trimester assessment?
So here again, we have to understand that preeclampsia has to be managed in the mother by delivery and in the baby by surveillance. There is no other treatment for preeclampsia except preventing by aspirin. So if you have detected by SFLT PLGF ratio, the best thing is by referring it to a place where it can manage a preterm delivery and manage the complications in the mother. So this is what the idea behind SFLT PLGF. So if you detect something, SFLT PLGF will tell you that, okay, there is a chance of worsening or there is no chance of worsening in the next 1 week. And if you feel that, okay, this patient can worsen, please refer it to a place which can manage those complications. And that is all. Adding aspirin, giving some medication, nothing is going to change the course of the disease. You can just manage the mother and the baby in a better manner if you refer it to a good place. That is the entire idea behind it. Preventing mortality in the mother and prematurity in the baby.
So all the other measures don't seem to work, isn't it?
Only calcium. Only calcium is the other preventive method apart from aspirin.
Yes. So the next question is, the screening advisable for twins with an with that rate of 75% acceptable screen positive rate. So do we screen with only PLGF or the ratio at 28 weeks in twins? So we have twins who came in with possible something or the other, like albuminuria. What do we do next?
So screening is right now in its nascent stage. So we are just struggling with singletons. So let us have more evidence on singletons.
I think it's a case-to-case assessment. Use all your obstetric practice of the last few decades and put it together to help the patient.
The screening we've done for twins so far is first trimester screening for preeclampsia. And we don't have enough data yet for screening for SFLT PLGF ratio for monitoring of twin pregnancies for preeclampsia available as yet with a good evidence base. So currently in twins, we will use it only for the prediction at the 12-week scan. So that's where we stand there. And then a question for Dr. Aparna Sharma: how do we read the results in a Congo red test?
So, sir, as you have said, so this is something like an upcoming test. So I would not say that, this is already established, but the results are very good. So I would begin by saying that it was actually developed as a textile dye. And it actually identifies the amyloid beta deposits. And it was developed for rapid diagnosis of preeclampsia in the hospital triage settings. So it is something like a urine pregnancy test. So this is a very interesting kit, and we have seen it in some cases. We've started the demonstration in some cases, and it is a very simple test. And how it works is that in patients who are supposed to develop preeclampsia will have misfolded proteins in their urine as early as 10 weeks before preeclampsia actually develops. And this has been seen in 3 studies before us, and in the product which has been developed. So if the woman who's going to develop preeclampsia, the urine is tested something very much like a urine pregnancy test. And if it is positive, so it is something like, this is going to develop into preeclampsia. So this is like a referral for the periphery. So we have the images, but sir, I think this is for the trial basis. And we are starting the trial. Finally, we've got all the permissions. So starting the trial in March. By 1st of March, we should be doing it. And in the next 6 months, we should be able to finish the trial. And I think this is something very, very useful for even for the peripheral places. So once the patient comes to be positive, there is a high chance that 89 to 90% prediction that it is the patient can develop worsen. So I think that's a good thing with the test.
That's something to truly look forward to. And then a clinical question, Dr. Chinmay: with a patient with severe gastritis and hematemesis, positive for PIH, for PE screen, do I give her aspirin?
No, if she has gastritis and hematemesis, she will have high blood pressure any which way, which may not be all placenta originated, because hematemesis in pregnancy is a very, very serious condition. And she will need to be assessed by the gastroenterologist definitely, because we must rule out esophageal varices and other problems that can be typical complications in pregnancy. So no, you will not give her aspirin, and she is definitely at risk, but she is at a greater risk for her own life and for many other things. So we'll manage all those things. And for the fetus, like Dr. Aparna said, we'll keep surveillance on the fetus. Let her have a normal diet, let her have rest as much as possible, and we will keep looking at the baby for growth. We will keep looking at the mother to keep her healthy, to be able to continue the pregnancy, because if her hematemesis gets worse, if her gastritis gets worse, we should not reach a condition where there's a maternal indication for termination of pregnancy. Because whenever there's a pregnancy complication and the mother and the child are in balance, the maternal health takes precedence. So suppose the hematemesis is because of some pressure on the esophageal veins, or there's some coexisting portal hypertension or something else there, you may actually reach a stage where the gastroenterologist will say, well, you need to terminate because I can't handle the pressure in the abdomen there. So we have to look at this condition individually, and let's not get too worried, because luckily we won't have too many patients. We've been using aspirin now for good about a decade or so, very liberally in obstetrics, and we don't have so many patients with gastritis. So this is one patient, she has to be dealt with at an individual level.
Excellent.
But certainly no aspirin.
So two questions for Dr. TL and Praveen. Please mention the angle while taking ophthalmic artery.
20.
Actually, if you can
Angle of insinuation 20.
Yeah, some 0 to 20 would be just ideal. Yes.
Yeah.
And the other question for you is that how do we add ophthalmic artery Doppler to our risk assessment?
Welcome.
Well, see, basically, when you take into consideration various factors like maternal factors, as well as the uterine artery, Plgf, and PAPE, this is also going to be incorporated, and the detection rates have gone up to almost 100%, with the false negative rates have come down to almost 2%. So that is the advantage of adding this ophthalmic artery into our screening protocol, so that we can improve the detection rate as well as decrease the false positive rates.
And a related question, so we do it at 12 weeks, and then we do it at 23-week scan, and then we do it at 36.
36 weeks.
Yeah, wonderful.
Yeah.
So that answers that question. And then our usual question for a transabdominal scan for uterine arteries, where I did not take the centile at the time of the NT scan, can I have a cutoff, please? Of course, you can't have a cutoff. I'm going to compromise.
Okay, 1.68, let us say. 1.68, but the range.
Cutoff. Cutoff, and we're not going to do anything about it.
Yes, yes.
And then a question from Dr. Sridevi. Should we still do uterine artery Doppler in a patient with known chronic hypertension? Dr. Chinmay, please.
Yes, sir, please. We should do it, because she is known chronic hypertension. She must be on medication for that. That must be managed. But we are interested in how is her uterine artery responding to all that. So whether it is because of maternal reasons or because of a placental reason, if there is any high resistance in the uterine artery, she is at risk of pregnancy complications. And we will use that uterine artery Doppler just in the same way for the risk assessment, except that in the history part, you will enter chronic hypertension positive. So we will get a risk assessment the same way.
Absolutely. So we will continue to use it. And then we've already answered Prasoon Bera's question on the role of how to handle recurrent pregnancy losses and the add-ons. And we have an excellent link now, which Dr. Aparna Sharma has sent us now. The question is, Dr. Aparna, if my patient can't take aspirin, do I have an alternative?
Sir, as I said, so there is no actual alternative to aspirin. But yes, in people who are calcium deficient, calcium is also known to prevent preeclampsia. So we should be taking calcium because calcium is for every antenatal patient. But calcium also has a role in prevention of preeclampsia, although it is not like aspirin, not anything like aspirin. It's not a substitute to aspirin, but it is just an information.
Wonderful. And a question here. If we do ophthalmic artery Doppler, can we do away with PLGF?
No, I don't think we can do away with PLGF. If you want to increase your detection rates, definitely you need to have PLGF with in your risk assessment. This is not an alternative for PLGF.
Yes. So we never replace, we add to whatever we do.
Yes.
Yeah. And then there's another question which we must clarify right now. And this is that if we do biochemistry at 10 weeks, we don't have NT in our risk assessment. So doesn't it decrease the detection rates? Yeah. And I want to give a nice, clear answer without any confusion on this, or may I? And Krishna, tell me if you disagree with me on this. How do you handle this? But tell me that first.
Sir, we have three gynec who were very pertinent, and they send patients first at 10 weeks for the biochem, and then we ask the lab to hold that results, and then we take all these readings of the PI, give our report, and then they give us the report, release the report with NT and all.
But we do the biochemistry the right time. We don't give them a risk at that time because it's only 6
time. Yeah.
And we add on the NT when we do it, and we add on the additional ultrasound parameters, and then we give them a risk. And then there's a question from Dr. Subayu Rizvi, and she says that, look, the fetus does become more vertical at about 13 weeks. So should I do my scan between 12 and 13 weeks and closer to 12 or closer to 13?
Yeah, there's a practical problem. Yes, you do get the fetuses vertical when you are doing it about 13 plus. But I think it would be preferable to do between 12 and 13, a little closer to 12 rather than closer to 13. Yes. Quite often that is an ideal situation where, particularly when you are looking for the structural abnormalities, when there is a situation where you may have to do a transvaginal examination, I think it would be preferable to do it at about 12 weeks, 3 days, or 12 weeks, 4 days.
Yeah.
Ideally.
12 weeks is ideal. 12 weeks plus is ideal. 12 weeks.
Many of us now try and time our appointments at 12 weeks, 4 days.
12 days, 3 days, 4 days.
Your dating scan. And then a question, Dr. Aparna, if someone misses a dual marker test at the time of the NT scan, and then we have a quadruple, what information on placental function or preeclampsia screening can we get from the second trimester analytes? I did touch on this, but could you please repeat that for us?
I think it is more of uterine artery Doppler in the second trimester than the analytes that can provide any information on the preeclampsia screening. So I would say that second trimester is more for aneuploidy screening if you have missed the first trimester. So do not miss out the second trimester quadruple. Let's do it for the aneuploidy screening, but do not expect any information on preeclampsia screening. So both of them are very, very important. For preeclampsia screening, go for the uterine artery Doppler.
Yeah, so although we have some rough guides like an elevated alpha fetoprotein or an elevated HCG as general indicators, statistically speaking, they don't perform as well as the other stuff.
And also, sir, if we screen at that point, when we are doing a quadruple test, we've crossed 16 weeks.
Yes.
So really at that time, there's no intervention which is available to change the course of things. So it's only about following this pregnancy, and the predictability of preeclampsia could even be better at 20 to 24 weeks in such cases where we could do uterine artery Dopplers at that stage.
Absolutely. So the risk stratification is really not something we're going to undertake until 23 weeks of gestation. And then there is a question from Dr. Aparna Setia about the role of repeating uterine artery PI if it's high during the first screen. And I did protect a slide that said, yes, we will do uterine artery PI at 18 weeks. And for those that are elevated, we will redo it at 23 weeks.
We will continue to do it every time, sir, because even if these babies develop fetal growth restriction later on, we need the uterine artery Doppler to corroborate that. So we are not doing again for screening, but we are doing it for monitoring. Absolutely true. So the surveillance continues, and so we will continue to do it. And then there was again a mention of Glyph, which is a glycosylated fibronectin. And then a patient says, then we have some repeat questions which came in. Patient on aspirin in preterm labor, what are the chances of postpartum hemorrhage?
because we haven't stopped the aspirin.
Well, you'll stop it when she goes into preterm labor. You will stop it at that point. And then,
but you manage PPH as you manage PPH, so it is all right. Like, you have to take it with the risk. So it doesn't mean that you will stop aspirin before it. So when the patient goes into labor, you stop aspirin. You have to handle that kind of obstetrics anyway.
Wonderful. And then a question: what will Congo Red be called when it comes to the market? It will be called Congo Red. Yes. Then
unless Aparna wants some other name.
no. Dr. Sridevi wants to know: can magnesium also be added?
So it has been not shown to be effective for prevention of preeclampsia.
And then there was a question on ultrasound findings in the liver in HELP syndrome. Dr. TL and Praveen, please.
Well, I mean, to diagnose HELP syndrome, I think we don't need to really do a hepatic scan, I mean, particularly in the fetus. I mean, the features which are actually described are very, very inconsequential. In the sense, they are not very specific for HELP syndrome.
And in the mother as well, there's nothing specific that we can
Specific
find.
about it. Yes, yes.
And then I think we actually ended up answering all the questions, but I need one input from Dr. Krishna Gopal, and that is that in terms of communicating with obstetricians who are not yet familiar with this, and where they do just mention 12-week scan plus NT-NB plus double marker. How do you plan to convey to them that we might as well do a nice proper combination including PLGF? Do you have a strategy that you might suggest to us for that?
Sir, actually, I will. What I say that if you add PLGF to it, to your dual marker, the cost is just mildly raised, just slightly raised, but the added benefits those we have in terms of both mother as well as the fetuses is much higher than what so if you see this bargain, so you will get more actually. So the kind of population I actually get used to in my practice, the first thing they ask that what will be the increase in the cost. So we have to tell them that the increase in the cost is not that much, but the benefits you will get in your in the terms of both fetus as well as the mother, so that is enormous. So this is the way I generally convince them to add PLGF to their practice. Plus actually for last a couple of years we were using Doppler of this one utrinatory. So basically it has also make these changes because if they think that we have added something to our scan to screen this factor preeclampsia, so if we add something to our dual marker also, then we will be in the higher position to screen more of the population and get those benefit. So I think that we all should communicate in this way, so that we can add PLGF to the dual marker, and our companies also give the much
Reasonable price.
cheaper price for that.
Yes. And so one parting question for Dr. Chinmay and Dr. Aparna: you'll agree that a double marker plus PLGF we should try and push it universally.
The concept of screening is to screen a low-risk population. Screening is a test done on an apparently low-risk population to pick up people who are apparently at high risk of a certain condition. So if all my patients are low risk, I'll do it for all of them. If my patients are already high risk for whatever reasons, then I won't gain too much by screening. I might use those biomarkers to prognosticate the condition. But screening should be done for everyone.
Correct.
Dr. Aparna, you will of course agree with that, but tell me, there's one last question on this one. What and that is this question of when to stop aspirin, 34 weeks or 36 weeks.
Generally, sir, we stop aspirin at 34 weeks mostly, but we can continue till 36 weeks. That's not a problem.
Yeah, because Kypros Nicolaitis insists
36.
36
36,
weeks,
correct.
even though 50% of those patients will deliver before 36 weeks anyway.
But we do.
But we just do it, yes. Well, thank you very much. Any parting advice from Dr. TL and Praveen?
I think as we are going to add this PLGF into our armamentarium, I think we need to even encourage doing ophthalmic artery for at least offer it as an added service. So that we can get, we start using this particular parameter and get a lot of information, because whatever the studies that are available, they're not huge studies. So I think from our side, from SFM, I think we can start gathering information from various places and try to, create a project which can help us in using this parameter also in our practice.
Terrific.
Measure the mother's blood pressure after the uterine artery Doppler examination.
But then, Chinmay, I'll tell you, I have been asking many patients who come to me for a first trimester scan, how a blood pressure was taken. It is really pathetic that none of them are being followed. And still we can risk calculate.
No, sir, what I'm saying is, for you, it's very common to scan organs other than the uterus. People like us have only learned scanning the pregnant woman and the womb. So putting a probe on any other part of the body leads to some degree of hypertension in the operator. But it's interesting, so I think we should try and learn that.
Yes. It's very simple. You come to me, I'll train you.
Yes, I will. I will. Definitely.
Before we end, sir, I think one important message about aspirin. Sir, I think there was still some confusion that there are 3 points about aspirin. Is that it should be started latest by 16 weeks. There is no point in starting after 16 weeks. 150 milligram and aspirin is to be given at night. So these 3 points are to be remembered for giving aspirin. There is no ambiguity.
To be continued till 34 to 36 weeks, because another thought people have is if the uterine artery Doppler gets better at 18 weeks, 20 weeks, should we stop it? So we need not stop it.
Yes.
Excellent. We have now come to the end of our time. Dr. Asha Jain has had to leave for an emergency cesarean section, but Dr. Tabassum is right here for our vote of thanks.
Thank you very much, sir. And at the outset, I would like to thank Society of Fetal Medicine for the seminar. And I would like to thank you, Sir Ashok Khurana, sir, for running this excellent clinically significant show today. All of us, including all the delegates today, really enjoyed it a lot. And I would also like to thank Dr. TLN Praveen, sir, especially for opening a new window, a new dimension in terms of ophthalmic artery Doppler today. I would also like to thank other panelists, Dr. Aparna Sharma madam and Dr. Chinmay Rath madam, especially for enhancing our clinical decision making today, and Dr. Krishna Gopal sir. I would also like to thank our President, Dr. Asha Jain madam, and our trade partners, the LifeCell and GE. And thank you, everyone. Thanks all the delegates who participated today. Thanks a lot.
Thank you.
Thank you indeed.
Thank
Good
you.
night.
Good night. Good night, everyone.
Yes.
Thank you, sir. Thank you.
Wonderful. Good to see you. Thank you indeed.
Good night, everybody. Good night.
Good night. Good night, Vishal.
Thank you, Vishal. Thank you very much.
Thank you.
Good night.
Good night, man.